Hi, welcome to this video on localizing lesions in the somatosensory system. Let's get started with a few primers on what to pay attention to when you're diagnosing a patient who presents with sensory symptoms. If your patient shows sensory symptoms, that means that there's a disruption along the somatosensory pathways, and the information is not reaching the cortex. The specific sensory pattern that's observed tells you which information is not reaching the cortex. Also, always start with assuming that there's a single lesion. Only if you come to the conclusion that a single lesion is not possible, start considering multiple lesions. Recognize which system and pathways are affected. Touch and pain from the body or face all follow different pathways. The symptoms tell you which one is affected. The laterality of the deficit and the lesion are very important pieces of information that help you localize the lesion. Pay special attention to laterality. Know where the different pathways cross the midline, where they decussate. This also helps with determining laterality. After you've examined your patient, note how the deficits are distributed on the body. Are they distributed in a nerve fashion, in a dermatomal fashion, or in a somatotopic fashion? If the symptoms are distributed in a peripheral fashion, then it's probably a nerve in the periphery that is affected. You can see the nerve distribution on this image here. Deficits that show a dermatomal pattern, like this, indicate that the lesion is located in the nerve root near the spinal cord or in the spinal cord itself. This image shows the somatosensory homunculus and how the body is represented on the somatosensory cortex. Lesions in the cortex, the thalamus, and the internal capsule produce deficits that have a somatotopic distribution, and that does not follow a dermatomal pattern. Here you see the difference between a dermatome pattern and a somatotopic pattern that is not constrained to a nerve or dermatomal boundary. Another important aspect is whether the lesion and the deficits are ipsilateral or contralateral to each other. If we define what a deficit is, it's a symptom reported by the patient. I can't feel my hand. I can feel my left hand very specifically. A lesion is damage to the pathway that is responsible for the reported deficit. Ipsilateral means the lesion and symptoms are on the same side of the body. They're ipsilateral to each other, like you can see in here. This is an image of the dorsal column medial lemniscus pathway. The receptor is on this side. There's a lesion here in the first order neuron, and here the lesion and the deficits are ipsilateral to each other. They're on the same side of the body. Contralateral means lesion and symptoms are on opposite side of the body. Here, the lesion is on the other side of the body. It's after the decussation of the dorsal column medial lemniscus pathway. It means a lesion here after the decussation produces a contralateral sensory deficit. So here's a question. See if you can answer it. Okay, the correct answer is they're ipsilateral to each other. As you can see here, the lesion is on the same side where the deficit is reported, where the receptor is, right? So that means they're ipsilateral to each other. See if you can answer this question. The right hand. Okay. What's important here to pay attention to is that there's a lesion maybe indicated by imaging in the left primary somatosensory cortex, the left. It's right here. Because it's in the cortex, it's after the decussation of the dorsal column medial lemniscus pathway, and the observed deficit will be in the right hemisphere, in this case in the right hand. They are contralateral to each other. Okay, here's another question. See if you can answer that one. The correct answer is D. Let's understand what happened here. The patient experienced a reduced sensory acuity in his right hand. So first of all, you have to find out which modality is this. So sensory acuity, that's discriminatory touch that's processed through the dorsal column medial lemniscus pathway in the somatosensory system. And that pathway in the cortex here, where the lesion is, ends up in the postcentral gyrus in the primary somatosensory cortex. Here you have the central sulcus, which um, delineates the precentral gyrus, the motor cortex, from the postcentral gyrus, the somatosensory cortex. So it will be either B, D, or F because it's touch. And then here you also have the posterior paracentral lobule, G, and the anterior paracentral lobule, H, right here, right? So the other piece of information is right hand. So now you have to look at the homunculus, at the distribution here, and you can see that the hand is distributed kind of in the middle here, where D is. B would be the hip or the legs, maybe, the trunk. F would be the face, jaw region. And G would be out here, more medially, that would be the foot and the leg. Okay, here's another question. Here the answer is E. It's basically sensory deficit in the right face. So what is important to pay attention to here, right? You can see that there's an abnormality here in the cortex on the left cortex. So this is the front, this is the back, this is the left cortex. This is in the somatosensory cortex here, and you can also see it says sensory disturbance. So it's in the left somatosensory cortex. Because you know that at this point all the information has decussated, that damage to the left somatosensory cortex causes a right-sided deficit. That means you can already eliminate all the left-sided deficits that are here. Now you look at the somatotopic organization, and you can tell that here is the homunculus, right? And this area represents the face. Looking at the available option, this will be the face, and it will be the face on the right side, which is E. Now, here's some distractors. Let's look at those. Why is it not this face here, bilateral? That's easy because it's a unilateral lesion. It's just in one part of the brain. If there was a similar lesion here on the other side of the brain, then you could have bilateral deficits like that. And why is it not a left-sided arm that could be very close to the arm? No, it is not, because this is a dermatomal pattern, right? Very clearly, and then a somatotopic pattern. So this would be most likely from an injury to the spinal cord or the nerve root. Okay, now let's add another level of difficulty here. The somatosensory cortex here is supplied with blood and irrigated with blood by two arteries, the middle cerebral artery here and the anterior cerebral artery here. What that means is that all the somatosensory cortex from the that receives information from the viscera, the face, the hand, the trunk, all the way here to the hip, is irrigated by the middle cerebral artery up till here. The leg, the foot, and the genitals are all irrigated by the anterior cerebral artery, right? So how is this diagnostically important? We can find that out by looking at this case. correct answer here is D, the right anterior cerebral artery. Why is it the right anterior cerebral artery? First of all, it's the right part of the brain. It's the right cortex. It's the right cerebral artery because the sensory loss is in the left lower extremity. It's in the left. It's in the cortex. The lesion is in the cortex. It has already decussated. So therefore, we have a contralateral relationship between the lesion and the symptom. And it's in the left lower extremity. We know that the legs are here located on the homunculus, and that is supplied here by the anterior cerebral artery. Therefore, we can see by just looking at the symptoms and knowing it's in the cortex that the right anterior cerebral artery was involved in this patient. Okay, here's another one. Okay, the correct answer here is A, the peripheral nerve, right? This is clearly following a median nerve distribution here, like half of that finger and the thumb and the index finger and the middle finger is very clear median nerve. Even though theoretically this could also be produced by a cortical lesion, but that's very unlikely that it would just look like that. So this is a clear median nerve distribution, and the likelihood that the peripheral nerve is damaged is very clear. Right? So you can see here, here's the middle median nerve distribution here. Carpal tunnel syndrome is really clear. Here also, here you see the median nerve, and then the dermatomal pattern looks very different. So it's a very clearly a peripheral nerve damage. Okay, here's another case. Okay, here the correct answer is A, right there. In this patient, you have a spinal nerve root transection. So that's right here. You can see this on the MRI here. This is on the right side of the body, right? And because it's at the spinal nerve root, it will have a dermatomal pattern like this one, right? And it will also be ipsilateral because that's before the decussation of any of those pathways. And therefore, it will be also on the right, like here. So this is a bilateral distribution that wouldn't happen with a unilateral lesion, right? And here we have both a body and face, and the face would not be affected, for example, by any spinal cord lesion. Okay. Here's another case. Well, this one is pretty clear. It's A. It's basically a complete transection of the spinal cord on both sides, right? Leads to sensory deficits and a lot of other problems here below the lesion, right? In both extremities, right? So that's very clear, and that should be very self-explanatory. Okay, here's another case. All right, the correct answer is A. Why is that? So the lesion is here, right, on the MRI where the crosshair is, and it's numbness. So it's very hard on the MRI to differentiate the pre-central from the post-central gyrus, but because it's numbness, we know it's the post-central gyrus, right? So it's touch. And then it's a focal lesion, we know that. So this will be on, on the MRI. We can see this is on the right side of the MRI. An MRI you have to always flip, so that's actually on the left side of the brain. And because in the cortex, it will be on the right side of the body. The deficit will be on the right side of the body. There's a lot of switching involved, but remember, when you see an MRI,